Good evening. What I want to do first, I want you all to give yourselves a big hand because you are the bravest and hardiest people in Ames, Iowa. We debated on whether we should do this, and we looked through the roster, and most of the folks who were coming were from Ames, so we knew this is a crowd that comes out. So we're very, very pleased that you braved the roads. Because this is a smaller group than we planned, we might condense a few things so we can get you home safe and sound a little earlier than planned. This is our annual heart symposium. I'll go through a couple of just housekeeping things. We're going to have two of our cardiologists speak first. And then we're going to have you all go, and some of you have been to these before, so you know the drill. We're going to have you all go just right down to the other room for dinner. And dinner, the recipes are based on the cookbook written by our keynote speaker tonight. So there's an extra little element for you. Restrooms, I'm betting you all know where they are, but you walk out that door, you go to your right, just keep going straight a little bit, and there's a welcome desk there. Restrooms are right behind there. Okay? All right. Our first speaker tonight, we're going to have, he's going to talk, and then you're going to see a video. If you haven't seen it, it's related to an article in the new magazine, new issue of the magazine. And if you haven't seen that, there's some out in front you can pick up. But we'll show that video, and then the Dr. Dotani will come on. And then we'll have our keynote, who I'll introduce later. But first up is Dr. Stuart Christenson, one of our cardiologists, who's going to come out and speak about coronary disease. Thanks.
Fantastic. Thank you all for being here. I appreciate you braving the roads. I just managed to come back from seeing some patients over in Jefferson and only saw 5 cars in the ditch on my way back. So hopefully they weren't anybody trying to attend this conference. I want to talk a little bit about coronary artery disease. It's a very common thing, very common entity that we deal with. That has to do with blockages in the arteries around the heart. And that's going to lead into Dr. Dotani's presentation in a little bit, where he'll talk about some of the treatments that we offer here for coronary artery disease. I put the title here often, Silent but Deadly, because one of the things we're going to talk about is how common this is and we don't even know what's going on. More than 3/4 of the time people have silent events. They have plaques building up in their arteries, they have reduced blood flow to their heart, and they're not even aware of it. And so you need to have a high level of suspicion and have close follow-up and be in discussions with your providers to try and treat this before it leads to other troubles. This picture I have on the front is, you never want to have a pathology specimen of a heart. That means something bad has happened to that person. And indeed, this is an autopsy specimen after somebody has passed away. And this is the left ventricle, the main squeezing chamber of the heart. And it should all be nice and red and plump muscle there with good blood flow delivered to it. But you can see down here, or up here, is a white scar that's been there for a little while. It's still got a little rim to it. It's somewhat fresh. So this is a scar. This is a heart attack that occurred days ago in this patient. Down here is another heart attack. It's even a little bit whiter, and it's thinned. And this is another scar where a person had a heart attack in a different area of the heart weeks or months or even years ago. And then here is another area. And this is brand new. You can see they all look a little bit different, but this is fresh. So multiple events in one person, and it's hard to know, did this person really know any of this was going on? Were they aware that they'd had heart attacks and were having damage to their heart? Well, that's what we're going to talk about, ways to identify that and prevent that in the future. So when we talk about this, we're going to talk about two very similar terms, coronary heart disease and coronary artery disease. The CAD, or coronary artery disease, that just means plaque buildup in the arteries. A lot of people start developing these plaques even in their teenage years, and they just progress over the years. You get these little fatty streaks in the vessels around the heart. And what we're talking about, we have a heart sitting there, and we have these vessels that go over the top. And even though the heart is filled with blood, it's these vessels on the top of the heart that supply blood to the heart, and that's where you get some plaque buildup in those vessels. Now, if you have coronary artery disease, that doesn't mean you've had heart attacks or other problems yet. It just means that you have that process, and we call that atherosclerosis. That's the process of plaque buildup in the arteries. And then coronary heart disease is another term where if you have the coronary artery disease and it leads to trouble, if it leads to chest pain, shortness of breath, that's what we call angina if you start getting symptoms from this. Some people have ischemia. These are all fancy terms I wrote down here that people talk about, that your doctors mention and you don't even understand sometimes. But the ischemia is when there's reduced oxygen delivery, reduced blood flow to the heart muscle. So that may be because you have a blockage there and you go walking a little bit fast, there may be reduced blood flow to a part of the heart. You may realize that, and you may have angina or chest pain, or you may not realize that. It may just be silent ischemia. But either way, it's reduced oxygen delivery to the heart, and it can cause damage to the heart. And then some people go on to have heart attacks. Fancy term for that is myocardial infarction. And there's a couple different types of heart attacks that we identify, and it can be sometimes confusing because some people say, well, I had a heart attack, and all of a sudden they rushed me off to get a procedure done as soon as I walked into the emergency room. And other people say, well, they said I had a heart attack, but they never really did anything other than change some medications for me. And that's because there's different types of heart attacks. And I'll show some more slides about that. The non-ST elevation myocardial infarctions or heart attacks are ones that we tend to treat with medications and may go on and do a heart catheterization or an angiogram at some point, but it may not be quite as urgent. If somebody comes with an ST elevation myocardial infarction, oftentimes as soon as we see that, people start picking up speed and we start getting that patient down to have a procedure done right away, because there's often a completely blocked artery that needs to be fixed before the heart muscle dies. And then some people have coronary heart disease that actually causes them to die. And we're going to talk a little bit about sudden death from heart disease. So these are some slides talking about plaque buildup in the arteries. This is an artery in cross section, and here's the lining, and then here's the muscle around the heart artery. And sometimes you get this little tear and you can get fatty streaks or plaque buildup, and over time that plaque can develop a narrowing there. And so this is where you may feel okay when you're sitting around, but if you get up and start to do too much, you go to the store or you go up a hill and you start to get a little chest tightness or shortness of breath. Oftentimes that's because of a blockage like this. Other times you're feeling fine, you're doing great, and all of a sudden you get this crushing chest pain. All of a sudden there's just something that's completely different and you can't breathe. Oftentimes what happens is you get a ruptured plaque and all of a sudden a blood clot forms. So it may have looked like this just a moment ago, but all of a sudden there's a blood clot there. There's no blood flow down that artery. And that's what oftentimes leads to sudden heart attacks. And this is another view where you have a normal artery here, but then sometimes you have this narrowing. And depending on how tight that narrowing is, it depends how symptomatic you are. You know, what can you do before you start to notice shortness of breath or chest discomfort? And then sometimes that blockage can be bad enough that you get this blood clot and you can get a heart attack. So here blood flow flows down this artery coming this direction, but all of a sudden there's a blood clot here, as it shows here. There's a blood clot and blood can't flow past there. And that's where you get this heart attack in this area of the heart muscle, and this heart muscle can die if we don't fix that blockage. So Dr. Dotani is going to talk in a bit and have a lot more fancy pictures to show some of these arteries and what we see and how we fix those. So this is an EKG in somebody who may have come in saying they get chest pain when they walk too far. So we do a stress test. And when the patient is on the stress test, we see ST segment depression. So we see just some ECG changes. And here, these little lines here should be coming straight across, just like these lines are straight across. These should be straight right there. And so this is sloping down. We call that ST segment depression. And oftentimes, if we give you a nitroglycerin tablet, or if you're on the treadmill, if we have you stop and rest, those will go away and it will flatten out. But that's a marker for blockages in the arteries. And this is the type of thing where we may say, oh, well, we need to evaluate this more. Maybe we should treat with medications, or maybe we need to do an angiogram to check it out, and schedule that at some point in the future. Okay. And we compare that to this. This is a different type of EKG, where somebody can also come in complaining of chest discomfort, but instead of those ST segment depressions, which you do see some depression here, but the more important thing is this is elevation. So this should also be straight across here, but instead this is elevated. This is much higher and going upwards instead of being flat. And that is a sign of an acute heart attack. That's something that seems to have happened fairly abruptly, and we want to get that person to the cardiac catheterization laboratory and get fixed very quickly. Or sometimes we can also give a clot-busting medicine, something called a thrombolytic, which will just break up the clot. But this is more of an acute situation. That's why when somebody says, well, I'm having chest discomfort, it's hard to know what's going on until you come in. We can get the EKG, we can take a listen, and we can do blood tests. So this information helps guide what we do and how fast we do it. I want to talk a little bit about the incidence of coronary heart disease. How often is it occurring? Some of the data says for a person who's 40 years old, 1 out of every two 40-year-old men are going to develop some consequence of heart disease throughout their lifetime, either a heart attack or angina or die from heart disease. So if you're a guy that's 40 years old, you have a 50% chance of developing some symptom of heart disease over your lifetime. And for women, it's about 1/3 of you, if you're 40, will go on to develop heart disease. So that's a fairly significant number of people. That's going up with age. So if we talk about that number in the 50-year-olds or 60-year-olds, the risk goes up much higher. Women seem to have the same curve over time, so their risk goes up with age. It's just men tend to go up 10 years earlier. And then women are delayed, whether it be hormonal changes or other things, but they just have this lag, but then have the same risk of heart disease after that. Now, one thing we will see is that heart disease has been decreasing over time. Unfortunately, it's still the #1 killer of adults in America. It's not cancer, it's not infections, it's heart disease. Even though it's decreasing, we certainly haven't conquered heart disease. Obviously, you all are interested in heart disease, otherwise you wouldn't have braved the storm to come in. And so I don't need to preach to all of you, but it is an important thing, and that's why we hold this symposium. Still, a major cause of death in developed countries, and 1/3 of deaths in people who are 35 years of age or older. That's about 17 or 18 million people in the U.S. This is just a graph talking about heart disease over time, and if you look, this is the number of deaths from cardiovascular disease, and this is started clear back in 1900, and back here people were dying of infections and other things that we weren't treating. We didn't have penicillin, lots of other things here, and then over time the incidence of heart disease and death from heart disease has gone up considerably, and now it's starting to come down a little bit. We're making some inroads with healthy lifestyles, stopping smoking, and some of the things we're going to talk about later on, I'm sure, with our featured speaker tonight. So mortality from heart disease is still a big issue. As we said, people are dying, even though that is declining. And why is it declining? Because we have better therapies. Dr. Dotani is going to show some of the information on our therapies. We also have decrease in risk factors. We're watching out for the cholesterol. We're stopping smoking, treating blood pressure, becoming more active. Unfortunately, some of those benefits are offset by that third item on that line. We have more diabetes and more people who are obese. And unfortunately, we haven't made as great of progress as we would have liked because of some of those issues. Even though death from this is declining in the United States, it's increasing in other countries as they start to develop the traditional American diet and start to smoke more. They're having their own issues. And so this is becoming more of a worldwide issue. This happens to everybody. This just isn't low-income people. It's not just high income. It doesn't matter who you are. Heart disease is going to come after you. Again, this talks a little bit about death rates in some of the countries that are more developed. And you can see over time, the deaths per 100,000 population has gone down considerably. And the red is the United States. And so our deaths have gone down. And we're trying to make improvements in this area with all of our treatments and taking aspirin and taking the statins for cholesterol lowering. That's remarkable improvements. Now, it's even here, though, it's still the #1 killer. So don't forget that. We've already talked about these, but these are the standard risk factors that so many of us have. We can't do much about our age, but as you age, you are at higher risk. We can do things about so many of these other things. You developing that, flip of the coin, 50% risk of heart disease throughout your lifetime does not have to happen. You can do something about that by trying to address these risk factors. This just talks a little bit about the typical distribution for heart disease, or for symptoms of heart disease. As we'll mention in a few slides, this is not everybody, but classically it's chest discomfort radiating into the left arm, left neck, or left jaw. So this is the typical distribution we worry about, but it never fails. Somebody comes in with, my right elbow hurts, or my right finger hurts, and that can be heart disease. So we don't know for sure, and we don't mind you coming in and saying, I don't know what's going on. I'm afraid. Can you help me with this? And leave it to us to help sort that out. The other thing some people talk about classically is the elephant sitting on the chest, this crushing chest pain when somebody's having a sudden heart attack. Those are the classic things that we should all be aware of. And if you have these symptoms, you need to come in immediately so we can get you taken care of. So that's the chest pain, but there are also many other presentations. Shortness of breath, just feeling tired, not having the same energy as you've had, feeling weak, just not sleeping right. Now that doesn't mean every time you have a bad night of sleep you need to call your doctor, but this is just something, if there's just something gnawing at you and something's not right, it can be that you're having some heart troubles. Some people just have nausea. Or for some people, as we started out the talk mentioning, it can be silent. You may not have symptoms. This is particularly true for diabetics. And they don't have the classic symptoms that many other people do. And we often say women have atypical presentations. They don't have the standard distribution of pain or the elephant sitting on the chest as often as men might. I mentioned earlier that this could be a silent killer. 75% of ischemic episodes are silent. So that means you are not having chest pains, but if we have a monitor hooked on, we can see that there's changes in blood flow to the heart muscle just with certain activities. 75% of those times, we can't detect that. There was a study done looking at people in the military who died from non-heart related causes. So these are theoretically young, healthy people that have died in combat or other reasons. They had autopsies. About 8 or 9% of those people had heart disease and didn't know it. And these are young, active people. These were pretty startling graphs, these next two. They talk a little bit about symptomatic ischemia and silent. So the blue is the silent, and you can see in all of these studies, most patients were not aware that they were having decreased blood flow to their heart muscle and potentially damaging their heart muscle. And that's why sometimes we try to do testing, stress tests, check your cholesterol, do some of these other things, even if you haven't had symptoms thus far. So now I want to talk a little bit about sudden cardiac death, because oftentimes this is silent until you present dead, not the way you want to present. 15% of people don't have any idea that they have heart disease until they die from it. And some people with sudden cardiac death can be resuscitated, but it's very uncommon. And the better way is to prevent the development of the heart disease in the first place. So we never want to be this person, leading a normal life, feeling good, off at work, and all of a sudden, just drop over, dead. Now I would hope in this group, you're not going to stand there and point, but you're going to be grabbing the AED at the closest station. You're going to be calling 911, and you're going to be taking care of this patient. But that can happen, and it happens all too often. And what happens too many times is a patient has a normal heart rhythm, and because of this silent ischemia or damage to the heart in the past, they develop this life-threatening heart rhythm, and the heart just takes off and races, cannot pump any blood, and the patient dies. So, my last slide, I just want to have us all really think about heart disease, help silence coronary heart disease, get in to see your physicians, get things checked on, and again, I know I'm talking to a group who's very interested in this since you're here battling the storm to be here with us, but let's get it on the front end here before we have to deal with this. And this happens all too often. 15% of the time, as I said, this is the presentation without any warning beforehand. That's what we want to try to avoid if at all possible. Dr. Dotani is going to show you some of the fancy tricks that we have to take care of heart disease, the tools and things that we can do, but you really won't hurt our feelings if you come in early and get this taken care of so you don't need to have some of these procedures. We love to see you, but it's okay to see you in clinic and at these events rather than the emergency room as well. Did you have a video you wanted to show?
Yeah, we're gonna show a video that we made in conjunction with an article in the magazine, and then we'll have Dr. Dotani come up and speak, and we'll have these the two doctors available for some questions after Dr. Dotani speaks. Thank you, Dr. Christenson.
Thank you.
Spend some time with Bill Cruz on his Boone County farm. You're likely to get tired just watching him. Bill puts in long days. Working up a sweat is not uncommon. But his trip to the livestock sale barn last spring was different. He was sweating uncontrollably and had no energy at all.
Just felt kind of a little lightheaded. I didn't know what was wrong. I just didn't feel good.
He knew he needed to get to the hospital. Bill's wife Zelda took the wheel and they headed straight for the emergency room at Mary Greeley Medical Center.
Dr. Dotani came in and checked me over and said, well, you are having a heart attack. And, oh, okay. And he said, I can fix it. So he explained what they were going to do.
I told them that we're going to go through the wrist artery, find out if there's any blockage inside, and if we do find it, we're going to fix it at the same time.
Within minutes, Bill was in Mary Greeley's cardiac cath lab, receiving life-saving emergency cardiac care. This is actual video from Bill's procedure, which shows blood flow 100% blocked to his heart. Most physicians access an artery in the patient's groin to thread a thin tube toward the blockage in the heart. But McFarland Clinic cardiologist Dr. Imran Dotani is one of a handful of doctors in Iowa taking a different approach, called radial artery catheterization.
Now the catheters are small enough we can go through very tiny vessels in the arm to do the same procedure, in which we look at the heart arteries, fix blockages, look at valves.
Accessing arteries through the wrist can mean less pain, faster healing, and less risk of severe bleeding for patients. Here you can see how the catheter is threaded through the blocked artery in Bill's heart. A stent is placed and then the balloon is inflated to clear the blockage. Currently, less than 5% of hospitals in the United States use this advanced approach to catheterization. Dr. Dotani has performed nearly 5,000 already and offers trainings for other physicians on the procedure.
Now I'm seeing people who have had their heart attacks 8 years, 9 years ago, and they're just doing great, they're happy, and that's been the best thing.
It actually is like 158/80, so it's working harder but still comfortable? Yeah. Okay.
Bill was in the intensive care unit when he first met with the cardiac rehab nurses. After discharge, Bill regularly attended rehab classes that helped him see the importance of eating better and exercising regularly. He says he was impressed with the skilled, knowledgeable, and friendly medical staff he encountered throughout the entire process.
Oh, we're very pleased with Mary Greeley. I had real confidence in what they were doing. So we didn't even think about going anyplace else. We went to Mary Greeley.
To learn more about state-of-the-art cardiac care at Mary Greeley Medical Center, please visit us online at www.mgmc.org/heart.
Can you guys hear me? Oh, I guess so. Well, good evening. It is quite interesting outside. I just came from outside. Driving is more dangerous than anything we're going to see here. So we are, as Dr. Christenson went over heart disease and causes of heart disease, along with one of the presentation is heart attack or sudden cardiac death or cardiac arrest. It is very commonly seen, very commonly is probably an overestimate, but commonly seen in our field with mostly with ischemia or heart disease where the blood flow doesn't get to the heart muscle. In this case, what I'm telling you about is this procedure and how to get the artery opened and get blood flow back in that area. The standard has been for many years to go through the groin, and for a person like me who does this for a living, our fear is always bleeding, and I'll tell you why that's our fear. And we want to prevent bleeding. I mean, even though it's a clotting problem, but most mortalities or complications that occur with our procedures is secondary to bleeding and not clotting. Clotting can be present in less than 1% of the patients, and bleeding can be anywhere from 5 to 25% of the patients, depending on access, age, sex, and their weight. And certain patients have higher bleeding. It's actually a Bell's curve. Really heavy people bleed heavily, and really thin people bleed heavily. And the middle ground usually have lower risk of bleeding. So, first of all, we have done these procedures for a while. You will see that first time, these have been attempted many times. The first time, actually, a catheter was put into our heart was through a brachial artery, which is right here, instead of a radial artery, but that's the first time anybody actually accessed the heart. Somebody who walked down the steps and took a picture of his heart showed that you can get into the heart without killing somebody. He was lucky. He could have killed himself there, but he didn't know better. It was a radiologist, so I won't hold him against him too much. So previously, when the stent was put in, the stents and balloons were so big and very unfriendly that they were such stiff catheters that you couldn't get them through a catheter which was small. And the biggest issue was to get the product into the blockage. And we had to use big catheters. When we mention catheters like 8 or 10 French catheters, these are very large catheters. We don't use 10 French catheters in coronaries anymore because, as I said, bleeding risk at that time were anywhere between 60 to 70% bleeding risks. So everybody who died from heart attacks was not because of heart attack themselves. If they got to the hospital, they died from bleeding. And so it got better. We have gotten to a point where we're using much smaller. Now we're using 5 French catheters, and we can do pretty much everything through 5 French, except for some complex procedure. We have to put multiple stents in simultaneously, and then we have to use bigger catheters. So radial artery became a very viable approach for us, which is an artery going into the wrist. First thing is, hand is very important. You want to keep your right or left hand. So we didn't want to lose blood flow to the hand because we were doing the procedure. So there has to be 2 arteries going to the hand. And normally there's a radial and ulnar artery, 2 arteries going. And if one of the arteries is blocked, then we cannot use that access because it puts the hand at jeopardy if in case there's a complication at the site. So if there's a number of people that we don't do radial artery catheterization in, it's because they only have a single vessel going down to their hand, and then we won't take the risk. So as you can see, historically, there have been a whole lot of these procedures done from a while ago, but because of the equipment, it was not as commonly used as it is now. It reduces, these are the advantages. Bleeding, obviously, comfort is a huge problem. Patients can sit up. A lot of people cannot lay flat for a long time. They sleep in their recliners. They have not been laying flat for years. And all of a sudden you say you have to lay flat for 4 hours or 6 hours. It's almost impossible for them. So that's one of the big benefits of having transradial interventions done or procedures done in which patients can sit right up and don't have as much risk of bleeding because this artery is so small that we can just compress it and it'll stop bleeding. We do use a lot of blood thinners, and unfortunately we have not been able to get over that hurdle. We still have to use a lot of blood thinners, which obviously increases our risk. I will go over. There is some studies. You can see that almost 40,000 procedures are done in this study. And they were showing that 20.5%, there we go, 20.5% of the patients were getting radial, and almost 80% of them were getting femoral. Now, I hate to tell you this, but this was done by French first. It was not done by Americans. It was then taken up by the Canadians. And Americans are, in Canada, in France, almost 80 to 90% of all the procedures are done radially. Maybe because they have more time. The American physicians in general have less time on their hand, and they are less willing to spend more time to do training because it's harder in the United States. That's a different topic, why they don't train here. But so you can see that there's an increased risk of bleeding. At 1 year mortality, almost 25%. That's very high. And normally it should be around 1.5% to 3.4%. But these numbers are much higher if you end up getting transfusions, whereas the transfusion rate is much less as compared to the one with the femoral artery. So there is, almost 5 to 10% increased risk, 10 times increased risk associated with bleeding of death. So therefore, it is a very serious problem that had to be dealt with, and therefore, current recommendations from American College of Cardiology and American Heart Association put it in there that it is a preferred method of intervention if possible. So these are some of the studies I'm going over. There's multiple countries involved. Sorry, I think that's this one. Multiple countries involved in these studies. There is still a lot of people who don't do heart attack patients. This is what we mention as primary PCI, this number. This is when patient comes in with a heart attack, like you saw Bill's video. These are people who come in with a heart attack, they're primary PCI, as compared to somebody who saw us in clinic and getting the procedure done. So you have to be very comfortable to doing a radial heart cath during a heart attack because things are moving much faster. We need to get to the artery much faster. So that requires a number of procedures under your belt before you can take this over. So you can see that very small percentage of people are doing, even in studies, who actually are people who do these as a living, they still would not do heart attack patients with radials, only 8% of the patients. So it is a big, let's keep going backwards, I guess. There's a huge problem with learning this skill. But we have to get there somehow by working more or having patients. I've yet to see a patient if a doctor comes up and says, well, this is absolutely new thing I'm doing. I don't know what I'm doing, but I want to try it on you. So they just seem to not like that. So this is one of the concerns in the United States. People are not willing to, whereas probably in France and Canada, they don't know that this guy is doing his second case. So it becomes a little harder in the United States to incorporate these newer techniques in your practice without going through a very large number of patients and practicing. Luckily, I learned this in fellowship, and I didn't have to go through this process, but I feel for the people who are actually learning this while they are practicing. So you can see that there is a clear evidence that this is the unity, this is the line which you want to be on this side to have lower risk, and on this side is higher risk, and these are different variables that are being used to look at which side is you have low risk. And just having a radial approach is itself a very significant finding that goes in favor of a better outcome. And same thing, bleeding risks, much less bleeding risk in radial arteries as compared to other different things, especially like you're using other bleeding, blood thinners can increase risk of bleeding. So I just mentioned this to you, that this is a big deal, and that's why we got to this point, is what we're doing, talking about radial. Now, more importantly is we are looked at from the government standpoint is how long it takes us for it to open the artery. A patient comes in through the door, and they don't get the point where they enter the door to the point they get the balloon up in their artery to open that artery. As you saw the picture of that artery opening up, it was 100% blocked, and afterwards it had wide open flow through it. We are required by some, we're using as a marker of our quality, and if we get the patients and have their artery open within 90 minutes. So you have to pick a procedure which actually can get you to be at that point in 90 minutes. Now, I don't have slides of that, but just to give you some idea that on average, if there's a study showing a graph of getting comfortable with radial angiograms. So they showed people who were doing 50, 100, 200, and 500, and how their time to get to the artery, opening the artery, and time to get actually successfully do the procedure actually increases, just gets leveled with an experienced operator after 500 cases. So you need 500 patients to do this before you get comfortable. Now, that's quite a significant number of patients to be comfortable with your radial angiography. So people try it. I'm telling you, there is a lot of my friends out there who try it, and they do 10, 15, takes them 2 to 3 times as long. The patients are waiting, everybody's mad at them, and they quit because they're like, I can't do this anymore. So it's a lot of investment of time to do this, and people train. We train people here, and then they don't do them for 6 months, and then they call me and they say, well, I tried it and it didn't work. So it's not going to work that easy, and they know it, that it is taking, it's a huge, it's a very flat curve of learning. It's not a steep learning curve. So it takes a while to get to a confident level. So we have to meet these requirements. Good thing is we have been able to meet these requirements within 90 minutes through our heart attack patients. And this is where we were talking about just today I did 2 cases. One case was extremely hard to get through the arm because they had multiple branches, multiple turns, and just because we do enough of them, we know the tricks of the trade, but if you're new at it, you won't know the tricks and be stuck and end up going to the groin. This is what our catheters look like. They're weird shapes. They're approximately 100 centimeters long, which is about 2.5 feet. And so we get one end of the catheter in our hand, and the other end is inside the heart where the arteries are. And you basically have to twist these catheters to find the artery. And this picture kind of shows you how we can twist these catheters within the heart and find those arteries, which are two different arteries coming off two different ostium. So this is, it takes a little bit of, I guess, practice to get used to doing this. But it's doable. You guys can do it if you do a few cases with me. So this is a patient with a heart attack. You don't have the initial picture, but I'll tell you, trust me, that this is all clot. And this is a catheter going in through the radial artery, and this is the similar catheter than what you guys saw in that picture. So we put this catheter in, and this little thing, that wire, is our access to it's a railing that we use to get everything through. Now, if you see the thrombus here, this is clot. The part of the clot has broken off and is down here. You can see that filling defect right here. So we have basically a clot that breaks off, causes another heart attack. Now, the clot that's broken off and gone down to the heart muscle, I can't do anything with that. It's already gone. But my goal is to fix this problem, which is causing the clots to go down here. And this is the other artery, which looks pretty normal. So we looked at the other side, always make sure that we're not dealing with something different. We have to know what our ground rules are and then accordingly move on. So this, I don't know if there's pictures of, I don't think there is pictures of actual results, but trust me, we got the artery opened up and the clot was gone. That we feel quite comfortable in this facility to do these procedures. We do, when a patient comes into the cath lab in our facility, all the cath lab technicians and nurses feel that this is going to be radial unless told otherwise. So we do enough of these that we feel we can comfortably provide, I would say probably the best option at this point available for having an artery fixed with a heart attack or with elective procedures. Now, we would always like to treat these blockages electively. If I had a choice, I would always have every patient be treated electively and never have a heart attack patient. First of all, they always occur at 3 in. It's really bad for me. And the other part is that it's just a lot of clot that I have to deal with. And the clot breaks off and keeps forming, and it makes the procedure much more complex. So I will stop here. I don't think there's any more slides. So if there are any questions, I'll be glad to answer them. But Dr. Christenson, I guess, was going to join me and see if any of the two talks you guys have any questions about. Yes, ma'am. That is the dye. So we can't see blood. We have to have something that has iodine in it, and the iodine is radio opaque, so we can actually see it on the x-ray, and that's how we normally would do an angiogram. And if there is a part of the artery that does not show up, that means it's blocked. So you could see that there was haziness or defects in there, which is consistent with clot in it. Because it can't go through the clot it'll go around the clot. So it'll look like as if there's let's see if I can. Can we run that? Or I don't know how to run that again. There we go. So if you look at this part, you can see that the dye is going around the clot, and it doesn't fill the artery as it fills it here. Well, it's going through the muscle and it goes on. Yeah, it goes with the blood flow. So once the blood flow is gone, then you have to re-inject to see the artery again.
You talk about 500 practice opportunities. Who do you practice on?
It's definitely not pigs.
No, I was just curious. Is there a mock-up, or is there something that
There
can
is a mock thing that are present in our meetings, and we can use them. And they say they're very realistic. I've used them, and they're not realistic. So actually, they have to learn them on patients. It's 500 cases on patients. So right now, most of the people who come in for training, they get 5 cases to do with me, and then they have to be on their own. Yes.
So is this 90 minutes for radial or femoral?
Yes. The question was if it is 90 minutes time for whatever access site it is. It doesn't matter. They don't care what exercise you have. They care that you get the artery opened.
Other questions? Come on, treat me like Phil Donahue.
Yes. Go ahead.
Oh, Mary.
Well, I think this probably goes to you, Dr. Christenson. You were talking about a silent type, and I wondered if one has a physical each year and so forth. Is there anything else that they should be doing? Of course, we hope they have healthy habits and so on. But how does one know how to prevent it if prevent a silent attack?
It's very difficult to detect, and we can't do a stress test every 6 months every time a person walks in the door or something like that. So a lot of it is by identifying risk factors. So if you have plaque buildup, if you have high cholesterol, or if you're smoking, we try to reduce those risk factors, so that should reduce the risk of silent events. There are other things that we're working on, and some things can be offered to tell us whether you are starting to have plaque buildup. Things like CT scans for coronary artery calcification that are offered here at Mary Greeley. We can see how much calcium are in the arteries, and the more calcium there is, the higher the risk of future events. Same can be true looking at carotids, at the thickness of plaque buildup in those areas. So there are other ways we can try to detect. Every once in a while we'll do electrocardiograms or different things in clinic to sort through these issues as well. But we don't have a great way of monitoring other than listening to our patients and saying, if you can go exercise for 40 or 50 minutes at the gym, that's a good sign. If you're getting short of breath just walking around at the store, then sometimes we have to go do other tests.
Is there a difference between classification that you said or plaque buildup in the artery?
Between classification, well, there are lots of calcification. So calcium is part of a plaque, and many times, especially if the plaque has been there for a while. So it's a marker. So the more calcium, the higher your risk of heart disease. But it's not quite the same thing. So just because you have calcium in a certain part of a blood vessel, that does not mean you have a blockage there. But it's another marker, just like we know higher cholesterol is a marker that you might have heart disease in the future.
Either one of you can answer this probably. If you are taking calcium for the bones, is that going to affect your heart muscles or coronary things?
We'll debate who wants to take that one. There was a study that came out probably a couple years ago now, talking about the higher amounts of calcium may increase your risk of heart disease. But that has not been studied real well, and there's so many other good reasons to take calcium for bones and other things. So that's a hard one for us to handle as cardiologists. That's why we look at each other. If your doctor has told you should take calcium for some reason, I would recommend you take the calcium. If you haven't been encouraged to do that by your physicians and you're just taking it because you want to be healthy, it may or may not be helpful for you. I know we've had a question down here, so I want to make sure.
was just wondering how tough your arteries are. Is that what's the cause of bleeding, like that you get a puncture by having the catheter in, or how, do you know what I mean?
The question is about, first of all, I want to mention that so is plaque buildup in your teeth is a risk factor. So, you know, there's a lot of things that we know. Taking calcium is probably, I don't stop people from taking calcium because they have heart disease. But the question was about getting why is there increased risk of bleeding in one versus the other? Is that correct? Is that
I was just wondering how hard
well, we puncture both arteries. That's how we get into the artery, is by puncturing the artery. We have to actually be inside. That is no. The reason for bleeding is because we made a puncture in the artery in a high pressure system, and we're giving blood thinners. So that will increase risk of bleeding. Obviously in the groin, it's deeper, and we don't have anything, we can't put our finger on the artery and push it down and hold the artery closed. So we can do that in the radial, but we cannot do that in the groin. So if it bleeds, then it just bleeds until it stops bleeding. And sometimes it takes a while. So with a lot of blood transfusions.
If I heard it right, heart disease or deaths from heart are going down in the U.S. but up in many other countries. Is it known why it's happening that way?
I think part of it is because we have now we've realized we have significant difficulties with heart disease, and we're trying to address that with medications and smoking cessation programs and encouraging activity with programs like this, whereas in other countries they are just enjoying the fruits of development, having more income, and smoking is still on the rise in many other countries, and obesity is climbing in other countries. And that's why their death rate, overall death rate from heart disease may be lower than us, but it is inclining as opposed to going down. We're trying. As I said, though, heart disease is still the #1 killer in America. So we are making progress, and I appreciate. We have a lot of nurses and cardiac rehab people and people who are really working hard to make progress, but we still need to continue to do that. I want to just take one moment in this group, and obviously I'm biased, and I will acknowledge that, but I practiced at the University of Iowa, or trained, and then I trained and practiced at Mayo Clinic before coming here about 6 years ago. And we had 15 interventionalists like Dr. Dotani up at Mayo Clinic, and one, sometimes two of the interventionalists could do these radial artery procedures. And as Dr. Dotani said, maybe 5% of hospitals are doing this. And now it's the recommended treatment if you're trained to do this. And it's something he's been doing since he got here, and there's so many other things like that that's offered at Mary Greeley. And to be quite honest, I would not have left some of my other programs and come back to Ames, Iowa, if we didn't have the technology and the expertise we have here. And it's a pleasure to work with a community of people that are interested in being here at these events and with an interventionalist like Dr. Dotani. And I just want to make a point, because sometimes we forget to do that, but this is something that is not done everywhere, and we're lucky to have it here.
Thank you both, Dr. Stuart Christenson, Dr. Imran Dotani. We appreciate both of your gentlemen's time. We know you're very busy.